distal radius fractures. This is a fracture, one of the more common fractures of the wrist that we see. The wrist is made up here of the two forearm bones, which is the radius and the ulna. And then these are those carpal bones that I mentioned before. So where the carpal bones meet the forearm bones, that's the wrist joint. The radius is a very common bone there to break. A nickname for it is a Colles fracture. So that might be something that you hear somebody say they had a Colles fracture, and this is what they're talking about. Causes of distal radius fractures, usually it's a simple fell on an outstretched wrist. Just tripped, fell, the common reactions, put your hands out, and the radius is usually what will fracture. And osteoporosis can be a risk factor for distal radius fractures. So whenever we see somebody with a distal radius fracture, it's just sort of a red flag that we want to mention. Talk with your primary care doctor. It might be worth getting some bone density testing at some point to make sure that there's not something that needs to be treated. High energy trauma, you usually see this fracture in younger patients when they've had something like a fall from a height or a car accident or something like that. These fractures generally can be kind of divided into simple fractures or more complex fractures. Simple fractures are fractures that are not really out of place. You can see the fracture line right across through there. But this is the normal alignment of that bone, so the bone hasn't shifted or collapsed or anything like that. So this is good alignment of it. Simple fracture can just be treated with a cast, usually casting for somewhere 6 weeks. Sometimes we switch to a brace at some point. After 6 weeks, then generally the cast comes off, get you into some therapy to work on motion, stiffen some of the cast, and get strength back and stuff. Outcomes are usually pretty good in simple fractures, and they heal up well. One caveat to that is with these simple fractures, we do watch them closely for the first few weeks. It's we tend to take weekly x-rays for about the first 3 weeks. Sometimes what can happen is a fracture will look good in a good alignment initially, and then it'll gradually just kind of settle a little bit and shift. So sometimes a fracture will look good, but then if it starts to shift and settle, it then needs to be treated with surgery. So for the first couple of weeks, we like to watch them closely and make sure that's not happening. More complex fractures are fractures that have multiple pieces. A lot of times they go up into the joint surface. They're out of place where this bone here should be kind of more angled straight up, but it's collapsed back like that. In these more complex and displaced fractures, they need to be treated with surgery. Typically, it's a plate here, a plate and screws. Go and get the bone back in the position it's supposed to be in, and put the plate and screws there to hold it in place. Usually the plate and screw stays in forever. Sometimes if there's an issue or it's prominent or something like that, sometimes we'll take it out after it's healed, but not too often. With these fractures, depending on the stability of the fracture, determines kind of how quickly we can get the patient rehabbing and things with it. We like to try and get into a removable brace fairly quickly, usually within about 10 days or so, and then get into therapy quickly to get the wrist moving, to kind of get things going with that. Generally, over the course of 6 weeks or so, we're working on range of motion and then gradually strengthening after that. And usually in therapy for 3 months to kind of get motion back, get strength back. Patients most of the time do pretty well from these fractures. The more severe or complex the fracture is, there can be more stiffness or there can be arthritis down the road, those types of things. But most people get pretty good function back afterwards. So another really common condition to affect the bones or the joint here is Basilar thumb arthritis, also known as CMC arthritis. This is this joint right here at the bottom of the thumb. So it's where the thumb meets the wrist here. This arthritis, again, it's a CMC joint, a carpometacarpal joint. So it's where the carpal bones meet the thumb metacarpal there. And this joint is a very mobile joint. It has a lot of swiveling kind of action to it. And so because it's so mobile, it tends to wear out early on in life. You can see here, here's a normal joint there. Here's an arthritic joint there. So you can see normally the joint should have this thick kind of cartilage on the ends of the joints. That's like that when you look at like a chicken bone, it has that shining white surface on it. That's what your cartilage looks like, and that gives the joints this smooth surface. Well, with arthritis, that cartilage starts to thin down and wear down, and so those joints start to get kind of raw, bony surfaces that are rubbing together, and that's what's so painful. You can see on the x-ray here, there's arthritis, there's not really any space there anymore, which would normally be the cartilage. Symptoms of this type of arthritis are pain at the base of the thumb, kind of in that meat of the thumb area there. common complaints are pain with pinching things, pain with gripping, opening jars is a really common one, opening doorknobs, turning the key on the ignition. Those all tend to be really common complaints with this type of arthritis. Weakness with pinching and gripping over time, limited thumb motion. Some people notice that their joint changes a little bit in shape. It can look more enlarged there, or some patients feel that they think it looks out of joint. And that's because over time, the ligament there tends to stretch and that joint tends to shift a little bit. That can be one of the factors that sort of leads to this arthritis as well, and that can change the shape of the bone. Diagnosis typically can be made on physical exam and based on patient's complaints. Tenderness in that joint there, pain with motion of that joint. So we do something called a grind test where you hold the thumb and kind of move it around in a circular motion, and patients feel pain there. Sometimes you can feel sort of a cracking, kind of crunching sensation, and it's pretty diagnostic of this arthritis. Carpal tunnel syndrome is common to have in addition to this arthritis because the arthritis causes kind of some swelling around the carpal tunnel, and it can have carpal tunnel symptoms in addition to the arthritis frequently. So we tend to examine for carpal tunnel syndrome as well. X-rays are done to diagnose the arthritis. You see narrowing of the joint space there, because as that cartilage, normally the cartilage shows up as a space. As that cartilage wears down, that space gets smaller. And so you don't see any more space as the bones start to get bone on bone. You can have large bone spurs that occur, which is just sort of the way the bone reacts to arthritis as it starts to enlarge and grow these bone spurs there. A lot of people hear bone spurs and think that bone spurs are a problem. The bone spurs themselves are not necessarily a problem. It's more the arthritis, which is the joint being worn down. So we don't really do anything to go in and remove bone spurs or clean up the joint or anything because the cartilage surface just isn't there. So you really have to treat the whole joint. So treatment, initially we try to do conservative, non-operative treatment for this. Splinting can be very helpful, and Melissa will touch on this more. Icing, anti-inflammatories, those can all be very helpful to try and control just day-to-day symptoms. Anti-inflammatories like Advil or Motrin. Tylenol doesn't tend to, it's not an anti-inflammatory, it's more of a pain medication, so it's not usually as effective for arthritis pain. Anti-inflammatories like Advil, ibuprofen, naproxen, or Aleve, those tend to be more effective for arthritis. Steroid injections, cortisone, can be very helpful for this as well. Like some of those other conditions we talked about, the cortisone is hopefully to cure the problem. In this case, the cortisone isn't going to cure the problem, but it can make it feel better for quite a while. Usually on average, patients get several months of relief, somewhere in the average range of 3 months or so. Some people less, some people more. So for some patients, a couple cortisone injections a year can sort of control this and make it tolerable. If all of that fails and you're still having a lot of pain and really affecting your daily activities, then surgery is very helpful. It's a very good surgery, but unlike some of those other surgeries we talked about are pretty minimally invasive, small recovery. This is a much bigger surgery. It has a lot of recovery time, but when it's all said and done, patients are usually very happy. It just takes a long while to get there. The surgery involves, so this is the joint here, that's the metacarpal, and that's the trapezium. Those are the two bones that are involved. So the surgery is to actually remove that trapezium bone. It's called a trapeziectomy, so you no longer have that bone rubbing on bone. Way ahead. There we go. And then you take a tendon here, there's this tendon, and you cut the tendon in the forearm here. There's multiple tendons that do the same thing, so it doesn't affect the function. And then that tendon is kind of brought through the thumb metacarpal to help suspend the space. And then the rest of it is put into that space to act as like a cushion or a shock absorber in that space. There have been many, many joint replacements that have been tried for this arthritis. None of them have been great. There's some reports of decent outcomes. There's a lot of reports of not so good outcomes. So really the interposition surgery that I mentioned, that's kind of the tried and true surgery, and that's what most hand surgeons do. It's a very complicated, complex joint, and so nobody's really figured out a good joint replacement for it. I think eventually one day there probably will be one, but nobody's there. After the surgery, patients are usually immobilized. Typically I use a splint, some surgeons use a cast. About 4 weeks of full-time immobilization. Move the fingers, but really the thumb is immobilized and not really moving out at all. And then therapy begins to start range of motion of the thumb, cut down to kind of a smaller splint to protect the thumb. Eventually, usually at about 2 months, we start some gentle strengthening of it and then gradually increase there. And find usually it's like 3 months, patients are sort of glad they had it done, feeling like they're starting to get back to some of their normal activities. 6 months, they're feeling pretty much back to normal life, but continuing to improve for up to about a year after the surgery. So this is the slow recovery. But most patients are very happy at the end and do return to their normal activity and strength. So our last topic here, kind of changing course a little bit, is something called Dupuytren's disease. This is a problem that affects the fascia in the hand. The fascia is a tissue that's just right underneath the skin. It's superficial to the tendons, so it's kind of between the skin and the tendons and muscles. And it's just this sort of kind of bristly material there that's normally there, but in Dupuytren's disease, it becomes abnormally thickened. And it can start out a lot of times as just little nodules, so patients just feel kind of a lump in the palm. Sometimes you can get a little pitting of the skin where the skin's kind of tethered down. And then eventually it can thicken into these cords that can occur there in the palm and into the fingers. And gradually those cords, if they become thicker and tighter, they can contract fingers down and cause finger contractures where you can't straighten fingers out. Here's some pictures of that. You can see a nodule here. You can see kind of that band of fibrous tissue there. Again, here you can see that thick cord there that's tethering that finger down like that. Dupuytren's disease. So this is the one condition we're talking about today that's more common in men than women. It's more common as patients get older, usually over 40 years old. In patients that have Dupuytren's disease at a younger age, it tends to be a more aggressive form of Dupuytren's with worse contractures and kind of rapid progression. There's a wide range of Dupuytren's disease. Some people just have nodules and they never progress to anything more. Some people have the cords and they're gradual, over many years, gradual progression of contractures. And some people have, again, more rapid progression or more aggressive forms of the disease. Not a lot is known about the cause of Dupuytren's disease. We do know that it is definitely genetic. Most patients, some people aren't really aware of family history, but a lot of patients are, my dad had it, or a brother, an uncle, or somebody had Dupuytren's at some point. It's usually related to Northern European descent, and some people call it Vikings disease because they sort of traced it back to the Vikings at some point. Not really any association with any injury or overuse or any specific work or occupational exposure. That's a common question I get is, was this caused by work or is this something that happened or something like that? And usually not. Occasionally, patients that have Dupuytren's disease, if they have an injury or surgery or something, it can sort of ramp it up a little bit, but it's not usually generally caused by anything like that. Treatment for it, when it's mild and early on, we tend to just observe it. If it's not causing any functional problems or anything, we don't recommend doing anything for it. Just the nodules, they sometimes when they're first starting, they can be a little tender, a little sore. Usually as that tissue kind of matures, it becomes painless. So most of the time, Dupuytren's is a painless condition. If the nodules are tender, sometimes a cortisone injection can kind of calm it down, but it's not going to make it go away. We don't generally remove the nodules because they have a very high rate of recurrence. A lot of times they come back, and sometimes they can come back with a vengeance and kind of be more aggressive. So we try to shy away from removing them. Treatment for Dupuytren's when it starts to be a functional problem, there's a test here called the tabletop test. You can see usually if somebody can put their hand flat on a table, we say don't do anything about it, observe it. If the fingers start to draw down and block you to where you can't straighten it out flat on a table, that's when we tend to offer treatments for it. Common complaints are it's hard to put gloves on, it's hard to get my hand in my pocket, things like that. And so those are usually why people seek treatment for it. There are different treatments I'm going to talk about here. There's something called collagenase or Xiaflex, needle aponeurotomy, and then sort of a traditional open surgery. Recurrence of Dupuytren's can occur with any treatments. So unfortunately that tissue is always sort of there and it can come back even with treatment. Most of the time, many patients it does not ever recur, but if it does recur, most of the time it's slow over many, many years. Some of the younger patients that have it in a more young onset and a more aggressive type of disease can have recurrence more quickly. Over the past 10 years or so, the treatments for Dupuytren's disease has changed quite dramatically. It used to be that it was treated always with a big open surgery, but there's been sort of some new advances in the past several years that are more minimally invasive. One is called a needle aponeurotomy, where a needle is used in several different spots there to try and break or rupture that cord to straighten the finger out. So these treatments don't remove the lumps and bumps there, but they're really, the goal is just to straighten the finger. That's just a small local procedure that's done like in a procedure room. Another advance recently is something called Xiaflex or collagenase, and this is an enzyme that kind of breaks down collagen. It's injected into the cord, and it's injected in the office on one visit, and then the patient comes back to the office a couple days later, and the collagenase kind of gradually weakens and softens that tissue, sort of dissolves away a couple little areas, so that then a little manipulation can be done to then break that weakened cord. These are both good treatments. They're much less downtime compared to traditional open surgery, but studies have shown that they have a higher recurrence rate than open surgery because you're not taking out all that surgery, or I'm sorry, all that tissue. But I would say for the majority of hand surgeons, these more minimally invasive treatments have become kind of first-line treatments before offering the traditional open surgery. There are certain contractures that are better treated with surgery because some of these treatments aren't as good at straightening certain joints and things. So it really varies depending on the specific case. Now this is a picture of the traditional open surgery for this. So it's big kind of zigzag incisions to go and remove as much of that tissue as possible. It usually does result in 3 straight fingers. So it's pretty effective. It does have a lower recurrence rate than some of the open minimally invasive treatments. But again, it can have some recurrence over time. There's a lot of therapy involved with this, a lot more healing, a lot more downtime. So for some patients though, it's not done nearly as much as it used to be, but there still are indications for it. It's a better option for recurrent Dupuytren's. So if you've had a treatment like the needle aponeurotomy or the Xiaflex and it's come back, the open surgery is going to be more effective for that. Certain joints that are contracted are more difficult to correct with the other treatments, and open treatment can be better for that. So really it's a matter of being evaluated and talking with the hand surgeon and determining what's the best option for your specific case. And those are the topics I'm going to cover.
We'll have Melissa talk and then have questions at the end, and then they can answer questions together. So you do a great job. A lot of questions they both can answer.
Hello, I'm Melissa, and I'm one of the hand therapists that works over at the Center for Orthopedic and Movement, formerly known as Synergy. So we underwent a big transformation, and you should come visit us. It's a really awesome center now. So I'm going to talk a little bit about the therapeutic interventions for the common wrist and hand problems. We've learned that carpal tunnel syndrome is a compression of the median nerve in that tunnel within the wrist. Dr. Peelman talked about the fact that the wrist has got a bony base and then a ligamentous top, and there are 9 tendons and the nerve that run into that area. Most common in women, 40 to 60 years of age, and we know that the symptoms are nighttime, typically with some numbness, pain, waking up, shaking the hand. The numbness will be in the thumb, the index, the middle finger, mostly, and frequently dropping items is another thing that we see with carpal tunnel. This may be related to repetitive motions, use of high vibration tools, poor posture, compressive fractures, and carpal tunnel can be associated with arthritis and diabetes, as well as obesity. So as you learned a moment ago, the carpal tunnel area at the base of the hand where the hand meets the wrist, and that ligament right across here is the roof, and then there's like the bone, and that creates the tunnel. And then you get all the tendons and the one nerve running into that area. Conservative management includes nighttime splinting. It's very effective to wear a brace that's got some metal in it, usually a little metal stay, that's going to hold the wrist in neutral, so that when you are sleeping, you're not sleeping with the wrists flexed. And now that we're getting into summer, you won't do that as much as you do in the winter when you grab the covers and you curl up. So your carpal tunnel may go away in the summer. You also might notice that some ergonomic education can be quite helpful. Think about all that we do on computers nowadays, whether it's laptop or keyboard. If you're resting your wrist on a pad, that could be actually compressing the carpal tunnel a little bit, could be compressing the wrist a little bit, compressing that nerve. So keeping the wrist neutral and not resting them on those things when you're typing can be very, very helpful. Doing some stretches during the activities that are very repetitive can be helpful. Pacing yourself during activities that are similar. I had a gentleman in California who would work on the computer all day for 8 or 10 hours, and then he went home and played his piano, and he wondered why he had carpal tunnel. It's like, well, maybe you shouldn't do both of those things on the same day. So things like that can make a big difference when it's all said and done. So just sometimes even changing the mouse where you are using the mouse with your non-dominant hand, so that you're getting a shared load there. So your right hand, if you're right-handed, maybe your right hand's doing writing and mouse use and all of that, and then you just switch the mouse to the left hand. Now you've got a little shared load where the left hand is actually taking away some of the issue with the right hand. There's also some nerve glides that we have some literature on in the back here that I could go over with you afterwards. And then sometimes modalities can be effective. Ultrasound, iontophoresis, sometimes laser treatment, not the kind that burns off tattoos, but just a much milder laser, almost like a laser pointer just above that actually, can be effective for the nerves. So here's a little diagram of the splint, just keeping that wrist in neutral, and then just some postural things that we look at. Floating the hands while you're typing, having the monitor at a correct height so we're taking tension off of the neck, where that can be a problem, as Dr. Peelman mentioned, maybe like a double crush where you've got an injury at the neck and in the carpal tunnel area, so just kind of be mindful of that. Sitting back in the chair, letting the chair do the support can be very helpful versus sitting on the edge of the chair, because when you sit on the edge of a chair, by the end of the day, what do? Slouch. And so therefore, if you're sitting back, you've got good support. And feet flat on the ground can be very helpful as well, just so you're not wrapping them around the chair or putting them up on something, which can stretch other nerves in other areas. The median nerve glides, I do have a handout in the back, and that's, like I say, I can go over those with you later. Basically, it was developed by a doctor and a therapist, and what they came up with was starting at a start point where the carpal tunnel and the nerve itself is kind of shortened, and then gradually lengthening that through a variety of positions. It's based on a nerve glide technique that was actually developed in Australia by a gentleman named David Butler, who's a physiotherapist down there. And he believed that tendons were under tension, as are muscles and other tissues. And so he came up with this concept of nerve gliding, which has been very successful actually in treating a variety of problems with nerves. The surgery is a release of that ligament, going in and actually cutting that transverse carpal ligament. Sutures are placed in for maybe 7 to 10 days, a light dressing, as Dr. Peelman talked about. And then afterwards, if therapy is necessary, oftentimes it's not. We usually only see the problem patients. But wound care would be included in that, any swelling and pain control, scar management, maintaining movement of the wrist and fingers. And we do talk about ergonomic and postural education, so that when you leave us, you're not going to go back and do those same things again where it could reoccur. We do grip strengthening, and then if sensory education is needed, we could do that as well. So that's carpal tunnel again. Okay. All right, trigger finger. So trigger finger, we know, is swelling of that tendon and the tendon sheath, and so we've got the flexor tendons are most involved in the trigger finger. So basically, it's a catching of that tendon as it passes beneath the pulling. And I love Dr. Peelman's analogy of the fishing pole. When you have that string going through those little knobs on the pole that kind of hold it in place, imagine tying a big knot in your string and then trying to pull it through one of those holes. It's not going to go. And that's what happens in trigger finger. So you get the tendon that pulls down through, and all of a sudden, either because the tendon itself is swollen or the ligament has gotten a little thickened, it won't go back, and you have to kind of physically pop it. It's very, very painful when that happens. And sometimes it becomes so painful that patients don't want to straighten their finger anymore, and then they end up coming in with a bent finger. I actually have a gentleman right now who came in with they thought was an injury to his middle joint in his finger, and actually it turned out that he had a trigger finger that was that he was protecting. So now that we figured that out, he's actually doing very well. So the thumb is affected most often, followed by the ring, middle, little, and index fingers. It's more common in middle-aged women. Yay, women! Yeah, hormones! Woo! Yeah. And the condition can be associated with arthritis, Dupuytren's disease, diabetes, or repetitive trauma. Pretty low in the repetitive trauma realm, except that My 97-year-old grandmother, who was still crocheting, got trigger fingers, so I'm wondering if it was all those years of crocheting. The anatomy is such that we talked about the tendon. So the tendon here is illustrated in the blue right there. And here's that big pulley right here, that A1 pulley, which sits in the hand right at the base of the finger, where the finger meets the hand, right at that kind of this area here. And like I say, when you draw the tendon in, it gets stuck under that ligament, and you try to force it out, and ouch. So there is a splint that we can make early on in therapy, if it's more of an acute issue, to block movement of the very first joint, called the MP joint. If we block that movement, we found, and our research has found, that you can still do a tendon movement without getting a full flexion of the finger, and preserve the movement of the upper joints, the glide of the tendon, without activating that trigger finger. So I'll show you a picture of the splint in a moment. We also talk about decreasing repetitive or prolonged gripping, because as you can imagine, if you've already got some swelling, you've already got an issue there, and you're doing like pruning the rose bushes, or cutting material for a project that you're working on, or doing a lot if you're driving and holding the steering wheel with white knuckles. Those types of things can actually irritate the tendon and create more of a problem. And then we talk, oops, I'm sorry, wrong button. I'm getting used to this. I'm old, so this is all new technology. So yeah, we talked about the doctor giving a cortisone injection. That can be very effective in acute trigger finger, because if it is truly a swelling-based problem, the cortisone will decrease the swelling, and then you can have good tendon function. There's also operative release of that pulley. And this is the splint that we can make in therapy. It basically slides, the white here across the bottom is just the adhesive Velcro that holds it in place. But this is the splint right here that just kind of mold around the finger. So I've blocked movement of that very first joint. I allow movement of the second joint and the tip joint. And by resting this area, we've had pretty good success with acute problems with this. Okay, so that was trigger finger. So deprivation is the problem with the thumb. That problem of, again, a tendon problem of a couple of tendons, one called your abductor pollicis longus, the other the extensor pollicis brevis. They run in a little compartment along the thumb side of the wrist. And the pain with movement occurs when you try to do like thumb extension, perhaps repetitive thumb movement, like using scissors or tweezers or pliers or something like that. You can get pain from lifting pots and pans or lifting a small child because of the lateral movement that the wrist is going to go through. It actually pulls those tendons across the radial styloid and makes it very, very painful. If the tendons are swollen or you've got some inflammation in that area, it's quite a painful movement. And that movement that Dr. Peelman talked about, the Finkelstein's test, please don't do that at home. You'll give yourself deprivations if you do that all the time, all right? So be careful of that. It's very common to new parents, golfers, home renovators, people who are doing a lot of hammering, tearing down walls, those kind of people we see in the clinic with this type of problem. So here's the anatomy here. So there's the two tendons right there going up to the base of the thumb, passing beneath the ligament. So similar to the trigger finger that we just talked about, except in a different location. And then here's that position, that picking up the baby. There's that wrist going toward the pinky. The thumb is down, and boy, what a stretch over that area. And you can imagine over time, with a lot of those same movements, how irritated that can get. So management, we try to stop the aggravating activities. So we try to teach new parents how to pick up their babies with maybe a palm up movement or a scoop movement rather than the underarm lift. We do icing and anti-inflammatory medication. We may talk about a thumb splint. You can go to Walgreens, Rite Aid, Wally World. You can get splints. Make sure if your thumb is involved, you need to have a thumb splint. You can't just get a wrist splint, because the wrist splints have a hole for the thumb, and they offer no support whatsoever. Those are good for carpal tunnel, but not for this type of problem. We can use modalities in therapy, ultrasound, iontophoresis. Dr. Peelman could do a cortisone injection or a surgical release of that compartment to alleviate the problem. So some of the splints over the counter would be something like this here, with the thumb included, wrist included, so that we're blocking that deviation movement. And this is one that I would make, a custom one, which is made out of a plastic material, held over Velcro straps, that's really going to be almost just like a cast and eliminating that movement. Okay, distal radius fractures. This is where my props come in. So Dr. Peelman talked about a fall on an outstretched hand. So if this is my arm and my hand, and I slip on some ice and I fall, that my hand is going to come back, and my hand's not going to come off, but it's going to come back. and basically that radius gets kind of driven right into the ground, okay? So this is the radius at the wrist. The radius is the bigger of the two bones at the wrist. It's wider here, and then the little ulnar's right there, and the hand sits on top. And so when you go and do your fall and you're coming down, wow, that radius is right there. So more often than not, the radius will fracture. Sometimes you'll get a little bone in the wrist called the scaphoid, and boy, that's just a pain in the butt. You don't want to break that. But you get this fracture, you have that push, that fall in the outstretched hand, and simple fractures are often treated with casting, and more complex fractures, the ones that are dislocated or have multiple pieces, those will be corrected surgically by Dr. Peelman with the plates, screws, and sometimes pins as well. So there's our push. So see, you've got to pretend there's, whoops, sorry. Yeah, so there's ice right here. Oh my goodness. And then there's the fall and there's the fracture. Ouch, yeah. We see a lot of those. Not so much in the summer. Okay, so the conservative management, as we talked about, was maintaining the range of motion. So say they're in a cast. And you get swelling when you have this injury, and you need to maintain your finger motion. So you come to see us, perhaps, or the doctor or the PA gives you instructions. Maintain your finger motion, maintain your elbow motion, maintain your shoulder motion. Don't wear your sling the whole time and come into us a month later with a total like frozen arm that's stuck to your side of your body. Okay? So very, very important. So you get a lot of instruction. It's very important to do those things early on. We do swelling control with either elevation, lymph massage, maybe compression stockings that we have, maybe even gloves. We have isotoner gloves that we give out to people that may work not so well under a cast, but once the cast comes off. And then splint support once the cast is removed, and then strengthening usually about 6 to 8 weeks as needed. Kids get their cast off, and don't you know, they're out doing cartwheels the next day. So there you go. It's good to be young. After postoperative management, the patient is seen in surgery. We usually see them about 7 to 10 days out because they're in a big bulky dressing afterwards, and that does a couple things for the patient. It actually helps with their swelling, their pain control, stabilizes everything. It keeps the wound nice and clean. And then so we see them afterwards. Usually after they've seen Dr. Peelman, the dressing will come off and they'll come down to see us for a splint, or they'll receive a splint in her office. And the treatments include splinting, swelling control, wound and scar management, range of motion for all of the areas, the wrist included this time, and the forearm. And then some light functional use, maybe at about 4 to 8 weeks post-surgery. It all depends on the x-rays. If there's good healing, we'll get the okay to move forward. If not, we'll hold back a little bit. And strengthening usually at about 8 weeks after. And we're always monitoring for any complications. There are some complications that can occur to the nerve, as well as to the sympathetic nervous system. So we're always kind of watching for that when we're in therapy. So this is a version of a custom splint that we can make. And that's a nice purple one. All right, thumb arthritis. So we know that the thumb has that saddle joint, and I'm going to hand around the model of the hand here. The thumb took a beating in our clinic. But you can kind of get an idea of the saddle joint. We know that we've got the metacarpal of the thumb right here, and then right beneath it is this bone called the trapezium. So as you look at it and it's falling apart, you just put that thumb right back on that bone, and that's that saddle joint. So you can just hand it around, as long as I get it back. So the saddle joint over time is so mobile, it wears down. And you think about all the movements the thumb can do. It's almost like the shoulder. You know, you can do a big circular movement, you can touch all your fingers, you can touch the bottom of your pinky, you can do something very wide, you can do something very fine. And it's really involved in almost any function of the hand use. You've got buttoning, tying shoes, squeezing out toothpaste, you know, writing. All those things involve your thumb. There's only very few hand activities that don't involve the thumb, and that's why it wears out a little bit quicker. So think about that. So we've got that saddle joint that's kind of worn away, the cartilage is worn away, and now you've got kind of bone on bone, and that's painful. And when it starts affecting your quality of life, that's when you want to actually hook up with Dr. Peelman. She can talk to you about some of the conservative treatments. I've got some really nice splints back there that work really well for like an earlier onset, and then eventually possibly a surgery. So you've seen slides similar to this, where you've got a normal cross-section of a bone. You can't see very well here, but I'm trying to draw it with my shaky hand. The cartilage that's on the end of the bone there, very normal, looks good, nice space there. And then you come over to the arthritic one, not any cartilage, no space anymore, and bone on bone. Very uncomfortable. So conservative management, soft and hard splinting. I actually custom make the hard splints. I've got one back on the table that you can look at and try on. Soft splints are available online as well as at some pharmacies. Again, it has to include the thumb and kind of be supportive. We do a lot of joint protection education. So we talk about things like in the kitchen, using your electric choppers and mixers, using padded items. Like there's a company called OXO that makes kitchen items that have a little bit more area to hold, like a rubber material to kind of hold on to, vegetable peelers and pizza cutters and things like that. And you think, wow, that's not really a big deal. But you think about all that you're doing through the day with your thumb, and then if you can just kind of take a little bit of that stress off with some of these items, it makes a big deal at the end of the day. Writing items. We have two really good examples on the back table of a bad pen for writing, the really skinny one that's cheap, and a really good pen that's got a built-up grip on it to give you a little bit more to hold on to. Now, you can make a bad pen a good pen by adding something to it, all right? So now it's not cheap anymore. So get the good pen. But seriously, anything that can give you a little bit more built-up grip or a little bit built up for a pinch can make a big difference. When you're thinking about replacing your gardening tools, look for things that have a kind of a spring opening to them. Like if you're out trimming your roses, instead of something that's thumb-driven, like traditional scissors, look for something that's got a spring in it that pops open, and it's more of a finger-driven motion than a thumb-driven motion. Things like that can, and with some padding on it, it can be very helpful. And they even have a lot of ergonomic tools now with padding on rakes and hammers that have a little bit of a bend to them so that you're taking less stress through the wrist. So as you're replacing these things or thinking about getting new ones, or when your birthday or Christmas comes up, have your kids buy it for you. All right, so we've got the splinting, we've got the education. We talked about some of the things. Pump dispensers are great for your body wash, your shampoo, your toothpaste, because then you don't have to squeeze. Okay, so little things can add up to make a big difference. Anti-inflammatory medicine, as Dr. Peelman talked about, and then she can offer a cortisone injection as well in like an early on kind of a conservative management. So this is a picture of the the thumb splint for arthritis that we have on the back table, the neoprene one. Very soft, very mobile, and quite supportive. And if you want to come back and try it on, I'm happy to let you do that. And then this is one that I would custom make. It's made out of a high temperature plastic material that can be custom molded to you. You get your choice of strap colors so you can personalize it. And then it's very nice because what it does is it actually eliminates movement at the CMC joint so that you can't lift up your thumb and you can't do a wide grip. And by taking away those two motions, we've now eliminated some of the stress on that joint. It's still quite functional. You can still do small things with the splint on. And like I say, you're welcome to try the one on that I have in the back room so I can prove my phone. Okay? Built-up grip examples. We've got a lot of little triangle-shaped ones for your toothbrush, your writing instrument, your paintbrush, your razor, your fork, whatever, to help build those up. And then a few gardening tools that have a little bit larger grip on them can be helpful as well. Post-surgical management. Okay, so when Dr. Peelman does the surgery that she talked about, where she takes out that trapezium bone and actually moves that tendon and does all of that, boy, that's a beautiful thing, and it really does take away the pain eventually. It's like she said, initially it's kind of a long, drawn-out thing, but boy, when you're done, you can't wait to have the other side done. You're like, why did I wait so long? So what we have is that it's called an LRTI, ligament replacement tendon interposition. We splint the patients in a long splint that we usually make in the clinic for about 4 weeks to really let that area rest and heal. We do some swelling control, some wound management at that time, and also make sure the uninvolved joints are maintaining good motion. And then with the doctor's approval, we usually trim out the wrist after about 4 weeks, as long as everything's looking good with the healing. So now you get your wrist motion back, but we're still protecting the thumb. We'll start some thumb motion, but then we're putting the splint back on to protect it, especially when you go out in public, places like the grocery store, church, everybody who sees you wants to shake your hand, and before you know it, you're on your knees. So keep the splint on for a little while. Strengthening occurs after about 8 weeks, and then adaptive devices or joint protection we always talk about during the whole process, just because, again, we want you to, with your new joint, to go back and be healthy and not have any pain. So this is the splint that we custom make initially after surgery, similar to this. I usually don't include the ulnar side of the wrist quite as much. Mine's more radially based, but close enough. Last one. Dupuytren's disease. So this is that one about the fascia. This is the one that's more common in men of like maybe Northern European descent. Usually there's a strong family history associated with this. I had a gentleman who was in his 30s when I was working in LA. He was a pianist, a concert pianist, and he had a strong family history of this and had multiple surgeries over the years that I worked there to try to counteract this because it kept coming back on him. He was so young that you know, he had that recurrence factor. Which isn't you know, necessarily the case, but for him it was. But it was always fine. So you get that thickening of the palmar tissue. It creates some nodules, cords, pits. It'll limit the ability to straighten the fingers. So that's when you get the fingers kind of drawing down in the palm. Maybe you've shaken hands with somebody, an older gentleman perhaps, and what you get is fingers in the palm instead of palm on palm. Okay. It's difficult to put gloves on, tuck your shirt in, retrieve items from your pocket when you've got that finger kind of constantly catching on things. Really good for golf, though. So it's most commonly seen in the ring and small fingers. Again, good for golf. All right, so here's President Reagan actually had Dupuytren's while he was in his presidency, and supposedly one of the first popes had it, and thus the benediction sign with the fingers being down. Just urban legend. But when President Reagan was in office, they actually made this really nifty splint for him out of like piano wire and stuff, so that it was barely visible. You know, you don't want your president to look like they're vulnerable, right? So here, you know, he had the surgery while he was in office. They made him a nifty splint and went on to, no one really knew about it. So there you go. Conservative management, Dr. Peelman talked about the needle aponeurotomy, where they take the needle and try to break up the tendon and get it to pop up open. The Xiaflex or collagenase injection, that's been a really successful one for us, where she'll inject the patient one day, they come back a couple days later, she actually manually like opens up the finger and gets some pretty good popping going on. And then the patient comes down to see me and we'll do a little dressing. Sometimes there'll be a little skin tear, we'll take care of that, do a dressing, take care of their swelling, and then make a nighttime splint so that the finger actually stays out straight and doesn't want to curl back down again, because as you know, scar is going to form and we want to kind of control that scar. So there's a drawing of the splint. I couldn't find a really good one on Google Images, so who knows. But anyway, so here's a typical splint that's got the ring and the small finger included in it, Velcro strapped in place, pretty much worn at night, occasionally maybe during the day if the person's got a strong kind of pull, you might have more during the day to kind of counteract that. Post-surgical management, we used to see patients where they would, the surgeons would do some techniques where they would actually remove the fascia and leave the wound open. It was called an open or McCash technique. And we would do whirlpool and wound care, and it was this big, big thing. And thankfully, we don't do that very much anymore. It was a big, big deal. So now we see the patients after surgery, they've been sutured up, we might see them within a week. We're doing their swelling control, their wound care, we're splinting, we're doing range of motion exercises, and eventually getting on to scar management, strengthening, and getting them back to all their functional tasks. And the ultimate goal is to have improved digit motion and great hand function. I had a few resources that I used. Special props to my coworker Javier for helping me with PowerPoint because he's young. And then I always give thanks to my parents just for being so supportive. So they were here last year, so this is more than that. Anyway. Thank you.